Welcome back to the deep dive. We are doing something a little different today. Usually we take a topic and try to expand your mind, but today we are looking at something that focuses entirely on the mechanism of keeping a mind and a body functional when the switch has been flipped off.
It is the ultimate deadline, literally.
We are talking about cardiac arrest, and I have to be honest, before digging into this chapter 7 of our medical source material, I had a very specific mental movie playing.
Oh, I know the one. The ER drama.
Exactly. The monitor beeps, the line goes flat, doctors start shouting, someone grabs the paddles, yells clear, and zap, the patient gasps and wakes up. It's dramatic, it's chaotic, and it's usually resolved in about 30 seconds.
It makes for compelling television, but it has done a terrible job of educating the public on what actually happens. The reality isn't about drama, it's about physiology. It is infinitely more complex, way more mechanical, and honestly, terrifyingly precise.
That's the word that stuck with me, precise. We aren't just talking about a heart attack here. We are talking about the cessation of mechanical activity. The pump stops.
Correct. And we need to distinguish that immediately. A heart attack or a myocardial infarction is a plumbing problem. It's a blocked pipe.
Right.
Cardiac arrest is an electrical or mechanical failure. The engine has seized.
And the mission today is to walk through that seizure. We're going to break down the electrical anarchy inside the chest, and then this incredibly rigid, almost military-style algorithm healthcare providers use to try and pull someone back.
I want to set the stakes right at the top, though, because the source material is very specific about the objective here. The goal isn't just ROSC, return of spontaneous circulation.
What does that mean exactly?
It means we can get a pulse back on a lot of corpses if we pump hard enough and use enough drugs.
That's a grim image.
It is, but it's the reality of the ER. The true goal, the only one that matters, is a patient who is neurologically intact.
Yeah.
We aren't just trying to restart a muscle, we are trying to preserve the person.
That distinction really frames the whole discussion. It's not just about staying alive, it's about the quality of that life.
Yeah.
So let's start at the moment of the stop. The text defines cardiac arrest with 3 specific signs. It's not just, clutching the chest.
Right. Clinically, it's defined by the absence of signs of circulation. So, number 1, no detectable pulse. The system has depressurized.
Okay.
Number 2, unresponsiveness. The brain has gone offline. And number 3, apnea.
No breathing.
Or no effective breathing. You might see what we call agonal gasps, sort of a reflex snoring or gasping. But that is not breathing. That is the brainstem fading out.
Okay, so the machine is down. But the text makes a really interesting distinction right off the bat about why it shuts down. It separates arrest into primary and secondary. This felt like a crucial concept for understanding what you're actually treating.
It dictates the state of the body when the lights go out. Primary cardiac arrest is usually what happens to adults. It's sudden. The arterial blood is typically fully oxygenated at the moment the heart stops.
So, to use a car analogy, the gas tank is full, but the engine just seized up.
Exactly. The oxygen is there, it just isn't moving. This is usually caused by ischemia, a lack of blood flow to the heart muscle, or an arrhythmia, but then you have secondary arrest. This is more common in children or in, say, drowning victims.
This is the empty tank scenario.
Right. It results from respiratory failure first. Lack of ventilation leads to hypoxemia, low oxygen, which leads to low blood pressure. And finally, the heart gives up because it's starved.
So in the primary case, the heart breaks the system.
Yeah.
In the secondary case, the system breaks the heart.
Precisely. And clinically, that matters because if you're treating a secondary arrest, your focus has to be on oxygenation immediately. But for the vast majority of adults, about 80% of sudden cardiac deaths, it's primary. The oxygen's there, we just need to move it.
Now let's get into the chaos. The text uses this phrase, electrical anarchy. I assume we're talking about the heart rhythms here, because apparently flatline isn't the only way to be dead.
Far from it. In fact, flatline, or asystole, is just one of 4 major states. And recognizing which one the patient is in determines everything about how you treat them. It's the fork in the road for advanced cardiac life support, or ACLS.
You essentially have 2 buckets. Rhythms you can shock, and rhythms you cannot shock.
Correct.
Let's talk about the shockable ones first. These seem to be the ones with a slightly better prognosis.
Generally, yes. The big one is VF, or ventricular fibrillation. This is the anarchy.
If we could see the heart during VF, what is it actually doing? Is it just stopped?
No, not at all. Normally, your heart beats in a synchronized wave. squeeze, relax. In VF, the ventricles, the main pumping chambers, are just quivering. It's often described as looking like a bag of worms.
That is evocative.
There is electrical activity, too much of it actually, but it's random. There is no coordinated squeeze, so there is zero blood being pumped out.
So the heart is basically having a seizure.
Electrically, yes. And then you have its cousin, PVT, or pulseless ventricular tachycardia. This is where the heart is beating, but it's beating so fast, we're talking incredibly rapid rates, that the chambers don't have time to fill with blood before they squeeze again.
So it's pumping, but it's pumping nothing.
Exactly. In both VF and PVT, the electrical system is active, but it's malfunctioning. These are shockable because a defibrillator is essentially a hard reboot. You aren't jump-starting the heart like a car battery.
Right.
You are shocking it to stop all that chaos, literally stopping the heart for a split second, hoping the natural pacemaker resets itself and starts a normal rhythm.
Okay, so that's the good, bad news. We have a reset button. What about the ones you can't shock?
That brings us to asystole and PEA. Asystole is your classic flatline. There is zero electrical activity. You cannot shock this because there is nothing to reset.
This is where the movies get it wrong, right? They always shock the flatline.
Every single time. And it drives medical professionals crazy. If you shock asystole, you are just cooking the meat. You can't reboot a computer that's unplugged.
That makes sense, grim as it is. But the one that really confused me in the reading was PEA, pulseless electrical activity. This sounds like a ghost story.
It is the most deceptive rhythm. In PEA, if you look at the monitor, you see a rhythm. It looks like the heart is beating, the electrical signals are firing correctly.
Right.
But mechanically, nothing. The muscle isn't responding, or there is no blood to pump.
So the lights are on, but nobody's home.
Exactly. And you can't shock that either, because the electricity isn't the problem. The pump mechanics are the problem.
The source mentioned a concerning trend regarding these rhythms, specifically regarding VF.
Yes. This is the so what of the epidemiology. The incidence of ventricular fibrillation in out-of-hospital arrests is declining.
Wait, isn't that good? Less electrical anarchy.
Paradoxically, no. It's actually terrible news. VF has the highest survival rate because we can fix it with a shock. If fewer people are presenting with VF, it means more people are presenting with asystole or PEA, which are much harder to treat.
So it's not that hearts are getting healthier.
No, it suggests that people's hearts are sicker. They are degrading past the point of VF into total silence before help even arrives.
So we actually want the chaotic rhythm because we have a tool for that.
Exactly. We want something we can work with.
Okay, so someone collapses. We've established the biology. Now we enter the chain of survival. The text lists 5 critical links, but I want to focus on the immediate response. The protocol is called CAB.
Right. And for those who took a CPR class maybe 10 or 15 years ago, this is a massive change. It used to be ABC, airway, breathing, circulation.
I remember that. You check the mouth, give a breath, then pump.
And now the guidelines explicitly prioritize C compressions.
Circulation is king. Why the shift? I thought oxygen was the priority.
It is, but go back to our primary arrest concept. If an adult drops, their blood is already full of oxygen. We don't need to add new air immediately. We need to move the freight that is already loaded.
You have to be the pump.
You are manually becoming the heart. And the physics of this are critical. The text specifies the rate, at least 100 compressions per minute.
That's the staying alive tempo.
Or another one bites the dust, depending on your outlook. But rate is easy. Depth is where people fail. You need to push down at least 2 inches or 5 centimeters in an adult.
2 inches. That feels incredibly deep. I feel like I'd break ribs.
You probably will. And you need to. If you are doing effective CPR on an elderly patient, you will feel ribs crack. It is visceral and unpleasant. But the alternative is death. So you push.
But the text highlighted something else about the mechanics, the recoil.
This is the secret sauce. This is maybe the most important part. You have to let the chest bounce back completely between compressions.
Why did that matter so much?
Think about a turkey baster. If you squeeze the bulb, you push air out, that's the compression. But if you don't let go of the bulb completely, it can't suck liquid back in. If you lean on the patient's chest because you're tired, you are preventing the heart from refilling with blood.
So you're squeezing an empty heart.
Exactly. You're doing all the work for zero output. You have to allow that negative pressure to pull blood back into the chest so you have something to push on the next beat.
It really is just manual plumbing at that point.
It is. And it's exhausting. That's why the guidelines say switch compressors every 2 minutes. Because even if you feel fine, your form degrades and the perfusion pressure to the brain drops.
And so we're pumping. Then the AED arrives. The machine analyzes the rhythm. If it says shock advised, we deliver the shock. But here is the part that genuinely surprised me in the text.
Yeah.
After you shock, you do not check for a pulse.
Correct. That is a huge misconception. The guideline is shock, then immediately resume CPR.
Why? I'd want to know if it worked. It feels counterintuitive to shock them and then immediately start pounding on them again.
It's all about physiology. Even if the shock works and converts the rhythm, the heart is stunned. It's been quivering. It just got hit with high voltage. It's not going to pump effectively right away. It's groggy.
It needs a jump start. No, wait.
It needs training wheels. It needs you to circulate the blood for it while it reorganizes its electrical and mechanical recovery. You do 5 cycles of CPR, about 2 minutes, to prime the pump before you stop to check if you have a pulse.
That requires so much discipline. You just jolted them with electricity, and instead of celebrating, you go right back to work.
Discipline is the whole game here. Diagnosis speed is vital because you are trying to prevent rhythms from degenerating. A shockable rhythm like VF can degrade into a systole if you wait too long.
So time really is tissue. Now, let's say the basic life support isn't enough. The ambulance arrives, or we're in the ER, we move to the drug cabinet. This is segment 3 of our dive.
Pharmacologic therapy. This is where we try to force the system to restart chemically.
First, we need to get the drugs in. The text lists IV, obviously, but then it mentions IO intraosseous.
Yes?
I have to admit, this fascinates me. If they can't find a vein, which I imagine is hard when there's no blood pressure, they drill into the bone.
It sounds medieval, but it's elegant. The marrow cavity of long bones, like the tibia in the lower leg, is a non-collapsible space.
Non-collapsible.
Think of a vein like a garden hose. If there's no water pressure, it goes flat. You can't hit it with a needle. But the bone is rigid. It's a hard pipe. You can drill a needle in there and push drugs, and they flush into the central circulation almost as fast as a central line.
That is wild. We can't find a vein, drill the leg.
Whatever it takes to get the drugs to the heart.
Okay, so we have access. Now, the heavy hitters. The star of the show seems to be epinephrine.
Epinephrine or adrenaline. It is the drug of choice for everything. VF, PVT, asystole, PEA. If the heart is stopped, you are likely giving epi.
The text says 1 milligram every 3 to 5 minutes. But why? What is it actually doing? I always assumed it was just to stimulate the heart cells, like injecting Red Bull.
It's much more about hydraulics than stimulation. Epinephrine stimulates alpha-adrenergic receptors. That causes intense vasoconstriction. It tightens all the blood vessels in the periphery, the arms, the legs, the skin.
So it's squeezing the hose to build up pressure.
Exactly. During CPR, you are generating very low pressure. By clamping down on the periphery, you shunt whatever blood flow you have to the essential organs, the heart and the brain. It improves coronary perfusion pressure.
So we are literally sacrificing the toes to save the brain.
In a manner of speaking, yes. We are redirecting all resources to the command center.
That puts the 3 to 5 minutes rule into perspective. You're constantly reapplying the clamp. Now, there is an alternative mentioned, vasopressin.
Vasopressin is a potent non-adrenergic vasoconstrictor. It hits V1 receptors. The guidelines state you can swap out the first or second dose of epi for 40 units of vasopressin. It's just another tool to achieve that same goal. Get the pressure up.
Okay, so those are the pressors. They squeeze the pipes. What about the drugs that fix the rhythm, the antiarrhythmics?
These are used when you have a shockable rhythm VF or PVT that isn't responding to the shock alone. We call it refractory VF.
The top dog here is amiodarone.
Amiodarone, 300 milligram bolus. It essentially stabilizes the cardiac cell membranes. It's telling the heart cells, calm down, stop firing randomly. It raises the threshold for fibrillation.
And if you don't have amiodarone, the text lists lidocaine.
Which most people know from the dentist.
Right. Novocaine, lidocaine. It numbs your gums. How does that help a heart in chaos?
It works on the exact same principle. It blocks sodium channels. Just as it blocks pain signals from a nerve by stopping the electrical impulse, it dampens the erratic electrical signals in the heart. It numbs the irritability of the ventricles so the natural pacemaker can take over.
That is a great connection.
Yeah.
Now, I have to ask about magnesium. The text mentions it, but it seems very specific.
Very niche. You only use magnesium if the cardiac arrest is associated with a specific twisting rhythm called torsades de pointe.
Torsades de pointe. Sounds like a ballet move.
It translates to twisting of the points. It's a specific type of ventricular tachycardia, often caused by low magnesium or certain drugs. If you don't have that rhythm, giving magnesium is basically useless.
Before we move on, I noticed a couple of things in the don't use pile. Atropine. I feel like I used to hear about atropine all the time for cardiac arrest.
You did. For years, atropine was standard for asystole and PEA. The idea was that it blocks the vagus nerve, which slows the heart. So if the heart is stopped, maybe unblocking the slowdown signal would help speed it up.
Logical.
Completely logical, but not supported by data. The 2010 guidelines removed it from the algorithm because multiple large studies showed no benefit. It didn't improve survival. It's a perfect example of how medical guidelines aren't static dogma. They change when the evidence changes.
So we just stopped using it.
Cold turkey.
Yeah.
The science moved on.
Okay, so we're pumping the chest, we're zapping the heart, we're pushing epinephrine to squeeze the veins. But the text introduces a really critical concept in segment 4. The detective
Right,
nurse.
because you can't just perform CPR forever. Especially with PEA and asystole, there is usually an underlying cause driving the arrest. If you don't fix the cause, the heart will never restart, no matter how much epinephrine you push.
The text calls these the H's and T's. It's like a pilot's checklist for a crash landing.
It is exactly that. You run through them mentally while you work. Why did this plane go down?
Let's run through the big ones. The H's first. Hypovolemia.
Low volume. Did they bleed out? Was it a car accident? Were they severely dehydrated? If the tank is empty, the pump can't work. The fix isn't drugs, it's fluids or blood transfusion.
Hypoxia.
Lack of oxygen. Is the airway blocked? Do they choke? We need to ventilate them better.
Hydrogen ion.
That's acidosis. Is their blood too acidic? This happens in prolonged arrests or things like diabetic emergencies. This is the one scenario where you might consider sodium bicarbonate to neutralize the acid.
And hypothermia.
Are they frozen? A classic saying in emergency medicine is, you aren't dead until you're warm and dead.
We really...
Absolutely. The cold preserves the brain by slowing down metabolism. We have cases of people drowning in ice water, being under for 30 minutes, and making a full recovery. You have to warm them up before you can declare that resuscitation has failed.
That is incredible. Then we have the T's. Tension pneumothorax.
This is a collapsed lung that acts like a one-way valve. Air gets into the chest cavity but can't get out. The pressure builds up and literally crushes the heart so it can't fill.
The heart is in a vice.
Exactly. CPR won't fix that. You have to pop it with a needle decompression. It's like popping a balloon inside the chest. The air hisses out and the heart instantly has room to beat again.
Tamponade.
Similar concept, but it's fluid or blood inside the pericardial sac, the bag around the heart, squeezing it. You have to drain it with a needle.
Amend the clots. Thrombosis.
Coronary thrombosis, heart attack, or pulmonary thrombosis, EP. This brings up a major debate in the text regarding thrombolytics clot-busting drugs.
Yeah, the text seemed hesitant. It says we shouldn't just use them routinely.
It's a double-edged sword. If the cause of death is a massive clot in the lungs, a clot buster could save them. But I am not doing CPR. You are likely cracking ribs. That is trauma. Giving a powerful blood thinner during trauma increases the risk of catastrophic bleeding, particularly in the brain.
So you might dissolve the clot in the lung, but cause a stroke.
Exactly. So the guidelines say, consider it if you know it's a pulmonary embolism, but don't just use it blindly as a guess.
It's a high-stakes gamble. Okay, let's say we win the gamble. The team succeeds. We get ROSC.
Return of spontaneous circulation.
How we know? Does the patient just wake up and ask what happened?
Rarely. Usually they are comatose, but the monitor gives us a clue. One of the most reliable indicators the text mentions is a sudden spike in PETCO2.
Carbon dioxide levels.
Right. When you breathe out, you exhale CO2. But that CO2 has to be brought to your lungs by the blood. During CPR, you aren't moving much blood, so the exhaled CO2 is low. The moment the heart starts beating on its own, a wave of blood rushes to the lungs, offloads a ton of CO2, and the monitor sees a huge jump.
It's the chemistry confirming the mechanics.
It is often the first sign the team sees, even before they feel a pulse.
That's fascinating. But the text warns that just because the heart is beating, we aren't out of the woods. This introduces post-cardiac arrest syndrome.
This is the aftermath. The patient isn't fine. They have suffered a massive metabolic insult. They face brain injury, myocardial dysfunction, and something called systemic ischemia reperfusion response.
That sounds like a lot of words for bad news. What is reperfusion response?
It's a cruel paradox. When oxygenated blood rushes back into tissue that has been starved, it actually triggers a release of free radicals and inflammatory chemicals. It causes oxidative stress.
So the cure of the oxygen causes damage.
It's biological whiplash. It causes cell death and swelling.
So how do we manage that? The text spends a lot of time on something that sounds like science fiction, therapeutic hypothermia.
This is one of the biggest advances in resuscitation. We intentionally cool the patient down.
We freeze them to save them.
We cool them to about 32 to 34 degrees Celsius, roughly 90 to 93 degrees Fahrenheit, for 12 to 24 hours.
Why? What does being cold actually do for the brain?
It suppresses those chemical reactions I just mentioned. It lowers the brain's metabolic rate. Think of the brain like a laptop that is overheating and glitching. We put it in sleep mode or hibernation.
You're slowing down time for the cells.
We are buying them time to repair themselves without the demand of running at full speed. It prevents swelling and permanent damage.
So we restart the heart, but we put the brain on ice.
Correct. The guidelines recommend this specifically for comatose adults after a VF arrest, but it's widely used. It's not without risk. It can cause clotting issues and infections, but the neuroprotective benefit is huge.
And speaking of protection, the text mentions we need to be careful with oxygen too.
Yes. During the code, we blast them with 100% oxygen. But once the heart is beating, you have to titrate that down. You want normal oxygen levels. Hyperoxia, too much oxygen, accelerates that oxidative damage we talked about.
They have to be precise. Not too little, not too much.
It's a tightrope walk. And you keep the head of the bed up at 30 degrees to use gravity to help drain fluid from the brain and prevent swelling.
This has been an incredible walkthrough. We've gone from the electrical anarchy of the arrest, through the physical labor of CPR, the chemistry of the drug cabinet, the detective work of the H's and T's, and finally, the futuristic cooling of post-arrest care.
It really highlights that cardiac arrest isn't a single event. It's a physiological journey. And it's a journey where every second and every decision counts.
So if we look at the big picture here, what are the key takeaways for someone listening?
First, the mechanics matter. If you are a bystander, push hard and fast. The decline in VF arrest suggests we are dealing with sicker hearts, so good CPR is the bridge to everything else. Without the recoil, without the depth, the drugs don't go anywhere.
You are the engine.
Second, the shift from staying alive to detective work is vital. You can't just follow the algorithm blindly. You have to think about why the heart stopped. Treat the patient, not the monitor.
And third?
The science is evolving. We don't use atropine anymore because the data said no. We do use cooling because the data said yes. We have to be willing to update our mental models.
It's a field that never stands still.
And that leads me to a final thought. We started by saying the goal is a neurologically intact patient.
Right.
We have mastered the ability to restart the heart, the pump. But the frontier now is saving the mind, the processor. Therapeutic hypothermia is just the beginning. It raises a profound question. As we get better at intervening in that gray zone between life and death, how does the definition of recovery change? We are extending the window where death is reversible, but we are also increasing the complexity of what it means to survive.
That is something to really sit with. We are tinkering with the very threshold of life.
We are.
Well, on that note, I think the most practical sign-off we can give today is this. Go learn CPR. You are the first link in that chain we talked about. Without you, the rest of the algorithm, the drugs, the cooling, the expertise, doesn't matter.
Absolutely. It's the most important skill you can have.
Thanks for joining us on this deep dive. We'll see you next time.